We're delighted to welcome back Professor Beverley Hunt, and also on stage with me is Kate Duhig, and online we're going to welcome Marian and Victoria Wilkins. So we're going to concentrate on the implication of a VTE prevention guidance. And first of all, we're going to start with Victoria Wilkins. Victoria is the safety and learning person in charge of NHS resolution, and she has knowledge of the litigation involved in VTE. So she's going to give us some very interesting food for thought in her presentation. So can we bring Victoria onto the platform, please?
Will hear me over in Belfast. So I'm just going to start sharing my slides.
Welcome.
Hopefully you will all be able to see those popping up on your screen now. Hopefully. So as introduced, I'm an Associate Safety and Learning Lead over at NHS Resolution, but I am also and continue to be a practicing midwife. So some of the research that we've been doing has been around VTE in pregnancy. And the background to this was that a significant concern was raised to us in relation to VTE assessment and prophylactic treatment for high-risk women in pregnancy, particularly in relation to early pregnancy and post-miscarriage or termination. So the decision was made that we would analyse claims data, and we requested two different data sets from 2016 to capture as many claims as possible, which would maybe also include claims where women had gone to their GP, not just through secondary services. And we wanted to capture those claims that were throughout the pregnancy period and until 6 weeks postnatal. And the current outcome of that work is that we are working with other organisations looking at how we can deliver proactively some relevant education to clinicians and pregnant people to reduce VTE in pregnancy and improve those outcomes. In terms of the data, what we are looking at is things like what stage of pregnancy a VTE occurred in, what type of VTE, what mode of delivery for those that were postpartum, the average time of diagnosis from first presentation, who did they present to and how many times before a diagnosis was made, and what risk factors were present for those women that did present with a VTE. Some of the initial outcomes can be seen here with reference to risk assessments on the chart on the left-hand side. 83% of the women who made a claim had known risk factors for VTE. 17% presented with no known risk factors. In terms of did women have a completed risk assessment, 67% of the women who made a claim did have a completed VTE risk assessment, meaning 33% of women did not have a VTE risk assessment completed. In terms of the outcome data when it comes to prophylactic treatment, we had a very small number of people who we weren't able to identify if they'd actually had any prophylactic treatment in pregnancy. For 61% of the women who'd made a claim, there was no prophylactics prescribed for them. Only 36% did have prophylactics prescribed. And of those 36% who did get prophylaxis prescribed, only 62% of them were actually given them. And some of the reasons why it wasn't given was things like delays relating to wanting to get results back, or the patient was discharged without the prescribed medications, or there'd been sort of concerns around bleeding following delivery, so there was some delays there. And what we could also see was that when prophylactics was not prescribed, it was an incomplete or incorrect risk assessment, which was the most common factor. In terms of these early insights, they're very much around VTE assessments, the discharge home, and also that primary and secondary care interface. So what we're doing at the moment is working with some of the different groups that you can see on this slide, such as the Royal College of Obstetricians and Gynecologists, Thrombosis UK, Embrace, MNSI, and the NHS. And what we're looking at next is reviewing those risk factors. Which ones specifically did we identify and which ones weren't identified? Looking at compliance with medication, how do we know that women are compliant with their medication? And then also looking at educational products and resources that we can develop and share with clinicians and with women to help increase awareness of VTE in pregnancy, but also to do about it. Who are the right people to go to seek advice and support? And I hope that just gives you a very brief sort of quick overview of some of the work that we're doing and what we hope to get out of it as well at the end of it as an outcome to help reduce harm that occurs from VTE in pregnancy. Thank you.
So I'm not going to put up any slides because I imagine if it's like every other BMFMS meeting, you've seen Embrace slides quite frequently already. As you will all be aware, VTE is the leading cause of maternal death in the period or during pregnancy and up to 6 weeks after the end of pregnancy now in the UK. And we know that the characteristics of the population of women giving birth are changing such that more and more women are at risk of VTE. We examined in depth the care of the women who died from pulmonary embolism in the report that was published at the end of last year. And there were several very recurring messages around thromboprophylaxis, which very much echo some of the things we've just heard from Victoria. I think two main areas for me to highlight, particularly for the audience at the BMFMS, are the women who are known to be at risk and the pathways to enable them to get early access to thromboprophylaxis and consultant advice, because we have a significant minority of women who die in the first trimester. Effectively, the peaks of deaths are in the first trimester of pregnancy and immediately postpartum. So making sure that those women who are known to be at risk are able to access thromboprophylaxis. So there's a rapid pathway through from either the midwife or the GP in early pregnancy is really important. We had examples of women who knew they were at risk, knew that as soon as they got pregnant, they needed thromboprophylaxis, but they were not able to access it because their GP was not able to access secondary care rapidly enough to enable the women to get low molecular weight heparin. The other area to highlight, and I'd be interested, I don't know whether you've got any of the Embrace assessors in the audience, is around the VTE risk assessment tool. And again, sort of echoes some of the findings that Victoria has. But the key finding for us is that the ability to calculate the score using the existing RCOG tool was clearly highly variable. And I have to say, varied between us as assessors. So we were not able to calculate the same score for the same woman between us. This has led to workaround solutions in some hospitals. So some hospitals have developed their own simplified tool, which in some ways does not follow the RCOG guidance and is not based on evidence. And so women who should have been eligible for thromboprophylaxis have not received it. However, the main message for us is that the the tool needs to be simplified, and we need to review the evidence base for that tool and make it implementable in practice. So one of the second key recommendations for that we identified in the Embrace report last year was around working with the NIHR and obviously the Green Top Guideline Development Group to develop a simple evidence-based tool to enable consistent risk assessment and access to thromboprophylaxis.
Very good, thank you very much. So what factors do you think we can change? I mean, our education here and what you're talking about is about obstetricians. How can we, what ideas have you got for getting this risk to go out to women so that they can be thinking about it at the time that they're doing their pregnancy test?
I don't know whether you're asking us or whether you want to ask the panel on the stage, but I know Beverley, you have Thrombosis UK has some useful tools for women, for people who are at risk that could be used in this instance.
Yes, we have patient information sheets on pregnancy and the risk of VTE, which you can download now from Thrombosis UK. But I've been working with Kate, and I think I need to hand over to Kate to tell us all about the programme that we're hoping to undertake over the next few months.
Thanks, Beverley. So I am working at NHS England as a National Specialty Advisor for Obstetrics and Prevention. We're doing a big programme of work on reducing maternal adverse outcomes in pregnancy, and one of our key areas of focus is on prevention of VTE. I'm delighted that Beverley is chairing that group, and we're thinking about multiple strategies with which to try to reduce risk, because as Marian has clearly identified, there are various problems along the pathway, not least because the existing RCOG tool is felt to be a bit confusing. Perhaps there's some changes in the wording that's needed, and Beverley's doing an evidence-based look at the risk factors that go into that tool to review whether there needs to be an update in what actually constitutes your score. And then we would aim to test that and make sure that there's at least consistency between different clinicians using that tool, agreeing for an individual woman, because that confusion, as Marian points out, with the Embrace assessors finding it difficult to agree, creates confusion and inequality. We are worried about those women who have identified risk in early pregnancy, who know they need heparin, and it's absolutely tragic to hear about maternal deaths where a woman has tried to get herself heparin and not been able to access it, and that shouldn't happen. There are also women who have multiple smaller risk factors who struggle to access services. So women who may have a score which requires low molecular weight heparin, but are scoring on more soft risk factors such as BMI, age, high parity, and those women often struggle to access services. So that also feels an inequality in terms of getting low molecular weight heparin to where it needs to be. One of the challenges that we have is from us as obstetricians, you're not really known to our services until you actually book your pregnancy. And as Beverley points out, that's 10 weeks on average in our trust, but again, there are inequalities in that. Women who live in poverty or are from Black and Asian ethnic backgrounds often book later, so may not come into our services until later. And so how do we get heparin to where it needs to be? How do we strengthen our communication with GPs and pharmacies to get the medication prescribed to reduce risk? So I think it's multi-layered, and there's not one size fits all. Beverley could probably speak more to some of the evidence that we're looking at and the things that, like weight-based dosing, which feels like a barrier to getting some women prescriptions. And we've recently gone out for expert consensus with the maternal medicine networks. So yeah, I guess I'll hand back to Beverley to talk a bit more about that work.
Thank you. So we want to make it simple for general practitioners to prescribe low molecular weight heparin. Kate has got some colleagues who are going to help her talk to the general practitioners, and hopefully we will enable them to prescribe low molecular weight heparin. I think this is a big ask. I'm not involved with that side. I'm more to do with the evidence base and trying to get a new tool out there. I'm also very keen, because we're going to be working with Thrombosis UK, that we improve awareness of VTE in pregnancy in the general population. And that isn't going to happen overnight. We may have a minister giving some announcement about what might be happening, but that will be lost. We have to do quite a lot of education to the public in lots of different ways. And then the last thing I think is really important is self-assessment of the women when they get pregnant. We should be aiming for someone gets pregnant and they think, oh, I need to do a VTE risk assessment. And they have a very simple tool they can find online, or when they book with the hospital, they automatically have to do this. It would be lovely to get to the stage of people do a pregnancy test, and on the pregnancy test, it actually says, oh, you've got a risk of VTE. Have you thought of doing a VTE risk assessment? Try this QR code. There are many ways we could go forward, but pragmatically, we have to work within financial constraints, don't we? But certainly Thrombosis UK will be taking on this issue in a big way and trying to get articles in women's magazines, in the papers, so that slowly we can increase understanding of the risk of VTE in pregnancy.
If anybody's got any questions, please post them on our app and we will look out for them.
There's some questions in the audience. There's nothing on the app at the minute.
Can I ask?
Keep your hands up, please, so that we can...
May I ask Victoria a question? Yeah. Victoria, thank you so much for coming, and you've highlighted that the claims you have with NHS litigation often relate to poor thromboprophylaxis because people aren't doing the risk assessment properly or not at all. How much money are NHS litigation spending on these claims over 5 years? Do you have any idea?
It's not something that we have to handle immediately, but it is one of the things that we have collected as we've gone through the data, is how much damages are being paid out. So we will have that data. I just don't have it to hand right now. But the other thing that we're looking at the moment as well is what open claims there are where damages haven't been paid out, but might be more recent claims. Are we seeing the same sort of themes and trends? And actually, does that indicate how much we might start to be spending in the future as well? But it is certainly something that I can provide that data for. If you specifically want it, I'm sure my email address will be floating around somewhere. So I can provide it for you if you really need that data.
I think it's very helpful when you're making a case for something politically, if you can say how much it's costing us, then I think it would be lovely to have that data. Thank you.
Hello, I'm Anita Goyal. I'm one of the obstetric consultants in Darlington. Thank you very much for lovely highlights about VTE and especially in early pregnancy. My question is related to BMI. We know that high BMI 50 is sufficient to start consider as high risk for thrombosis and start them on prophylactic enoxaparin. But below that, is there a cutoff you think they should be started on, like BMI 45 or 42 or something like that? Because BMI 40 is actually considered as not as high risk as BMI 50. Is there anything in between?
So when you have a risk such as obesity, where you've got a linear relationship with VTE risk, then you have to have a cutoff at some point to say, okay, at this stage we need to consider thromboprophylaxis. So I think 50 or 40 is as good as any, but we will be looking at this again. I did show you this morning those amazing curves from California showing that the risk antenatally of women who had a BMI of 40 or 50 was 10 times background risk, and then postpartum, if you have that BMI, it's 13 times background risk. So these are really high risks. So we need to look at them again, but we are going to need some point at which we say, let's give thromboprophylaxis. And then we need to say, how much thromboprophylaxis do we give them? And that is a very difficult question. I think I've shown you that fixed dose low molecular weight heparin works very well. In women, probably up to about 120 kilograms. But we are dealing with some very, very large women, and we need to just sit down and think about what we're going to do about them. So I don't have an answer, but your questions are very helpful, so thank you.
I'm Marian van der Ven. I'm an obs and gynae consultant from Frimley Park Hospital. I do maternal medicine, but I also still do gynecology. The last couple of months of my own course, I seem to be being a magnet for ectopic pregnancies that rupture in the night. And I've had some women with 2 to 3 litres in a peritoneum. And I just couldn't help but wonder if we have more women on low molecular weight from conception or from positive pregnancy tests, what is the impact going to be on ruptured ectopic pregnancies? How much blood loss are going to have? Are we going to be able to get to them in time? And also the occasional miscarriage that can have a lot of blood loss as well.
So I love low molecular weight heparin, and most non-hematologists just think of the risk of bleeding. You have to remember that most people on low molecular weight heparin at a thromboprophylactic dose are not going to bleed to death. This is a small dose. Yes, they will bleed more if they have an internal bleed, but it shouldn't be catastrophic, unlike full dose. And when you tell me about that, those women with ectopic pregnancy, they're very immobile, aren't they? And I showed you all the data showing stockings are useless, but what I didn't show you was the fantastic data on intermittent pneumatic compression. If you use intermittent pneumatic compression, you're getting the same reduction of VTE as you are with standard low molecular weight heparin. So maybe we need to be thinking about women with ectopic pregnancy immobilized in bed because they're in so much pain, actually having IPC instead of heparin. What would you think about that?
I don't know if it's helpful for me to come in just to talk about the women who die from ectopic pregnancy. We've not had any of those women who are on low molecular weight heparin thromboprophylaxis. And as I'm sure you'll appreciate, the differential diagnosis essentially for women who collapse in the first trimester is between ectopic and pulmonary embolism. What we have seen is that some of the women who are on thromboprophylaxis who have come in with symptoms suggestive of a PE, it has been assumed not to be a PE simply because they are on thromboprophylaxis. So I think one of the key messages is to emphasise that even thromboprophylaxis is not always perfect. You may well have said that this morning, Beverley.
Oh, Marian, thank you for reminding me about that. We are reducing the risk. And one of the issues about thromboprophylaxis and pregnancy is we don't know by how much we're reducing the risk. We have beautiful surgical studies showing we're reducing risk by about 70%. In medical patients, about 50%, but in pregnancy, no data. So another reason to be doing more trials of thromboprophylaxis. Thanks, Marian.
So I've just got two comments, really. I mean, I think the first one that's been highlighted is the fact that the VTE risk assessment is so open to interpretation between clinicians. So you can sit in a room of obstetricians and everybody, the woman will score a different score from everybody. So whatever, and I haven't got a suggestion, but whatever tool we now use or we're going to use has got to be much more prescriptive so that we can tighten that risk assessment, I think.
And you're an obstetrician with 5 years at medical school, with a background knowledge of what a flare of lupus is, which if you go to ask some of the midwives whose training is in healthy pregnancy, or the nurses, they don't really understand what a flare is. And when you put some words in and say severely unwell, they don't really know what severely unwell is. So yes, we have to get the wording as best we can. It won't be perfect for everyone, but it needs to be very simple. And words like phlebitis would need to be explained on it, because not everyone knows what that is anymore. So thank you for that point.
I think the other point to make is we're going to be very at risk of this sort of crossover between early pregnancy and obstetric care. So it's already been noted from your data this morning that a significant number of women have died in the first trimester because they haven't been able to access prophylaxis. And the question is, these women sort of fall between two stools, don't they? They're almost too early to go to the antenatal clinic and get into the pathway that way, and then nobody really knows what to do with them in a gynecology setting because of the early pregnancy. And I think that there's got to be some tightening up of that guideline to stop these women sort of falling between the cracks.
Kate, that's your bit.
Thank you. Yeah, no, I couldn't agree more. And I think, as Beverley mentioned earlier, you know, the termination providers feel a bit forgotten. So we're trying to bring other professional societies around the table. So I've been talking to the Association of Early Pregnancy Units. We're reaching out to the British Fertility Society, and as Beverley said, the BPAS and NUPAS, because you're right, it's a real gap, isn't it? The GP is a really important link, but there are some issues such as, you know, low molecular weight heparin has to be initiated in secondary care. So you get this gulf of women who have not yet booked, have not yet hit our services, and had a risk assessment. So we have to strengthen what we do before pregnancy and think about where women might be going. I'm going to share some data later, but 150,000 women go to accident emergency a year. So that's about a quarter of all women who book a pregnancy, end up with a pregnancy booking in MSDS, will have an attendance at A&E, and about 94% of those are in early pregnancy. So there are opportunities before women come into our services to think about how we can strengthen access, increase risk assessment. So I think it needs a broader approach.
I've just got a question too. My name's Sarah Kenyon. I'm part of the Embrace collaboration. I guess I just wanted to pick up Marian too, and I fully appreciate you only picked up two of the points, and that's the gap between postnatally. When women go home, they quite often go home without a prescription or not understanding what that prescription's about. And it's really just to encourage community midwives to kind of reiterate that the women need to take it and make sure they are taking it, because we saw quite a few of that, Marian, didn't we? So it's really just the gap in postnatal care. And also the midwife leaves at 10 days, 2 weeks, and the low molecular weight heparin continues to 6, and who's picking that up and making sure they're taking it?
Yeah, to echo that, we saw some amazing examples of where community midwives, or indeed the health visitors, had been helping women to administer their low molecular weight heparin. So some really good examples of exemplary care, but still, as Sarah pointed out, women who are either not being prescribed or not accessing their prescriptions. So we do need to think about whether women are administering their low molecular weight heparin. I guess the other point I just wanted to pick up on that the post-pregnancy loss period, which is equally as important as the postpartum period. And I know that you're picking up on that with some other providers, Kate, but for those women, it doesn't necessarily need to be low molecular weight heparin, but they do need thromboprophylaxis just as much as women who have given birth.
Hi. So I work in quite a busy DGH, and we've recently brought in, over the last sort of year or so, monitoring anti-10A levels. I wondered what your opinions was on that.
When are you using them?
Well, it's still a work in progress, but a lot of times, particularly if they've had like an estrogen-provoked VTE previously, that's the most common time. But it's a bit hit and miss at the moment.
So there are no studies showing what anti-10A levels are required to give thromboprophylaxis or treatment. Low molecular weight heparin has predictable pharmacokinetics. If everyone here got a dose, we'd all get roughly the same predictable levels. I religiously, obsessively monitor anti-10A in my antithrombin deficiency pregnancy because obviously heparin potentiates antithrombin and they haven't got any, so we're flogging a dead horse. So some of them on vast levels. I was sitting there doing an email and I've just put someone up to 120 milligrams BD, and she's of normal weight because she needs more to get anti-10A levels. But otherwise, they shouldn't be used routinely. They're giving you a false hope. You're going for a level, a peak and a trough that someone's made up somewhere that has no bearing on clinical outcome. So it feels good, and it feels like you're doing something, but I think it's a waste of money unless they've got antithrombin deficiency. Sorry to be so harsh.
Thank you very much for your talk earlier. My name's Cara Dant. I was really interested, I think I understood you right in saying that pre-existing diabetics, not so much, but it's the GDMs having the odds ratio of 2.5 that surprised me. A lot of these guys score maybe 1 for a BMI, but they're certainly not ending up on heparin by that alone.
So it's a new finding. It's in one paper published since RCOG guidance, but it does suggest it's those who have gestational diabetes who have the increased risk of VTE rather than those who go into pregnancy with diabetes. I can't explain it, and it is only one paper, but it is an interesting finding, and quite what we do with it, I think we've got to think through.
I think the Embrace recommendation as well from last year's report was very clear that we need to really look at the VT risk assessment tool that we're using, but part of the recommendation was aimed at the NIHR about generating new evidence. So we definitely need more research in this area. And I guess it remains to be seen what will happen with that part of the recommendation, but it's going to be key to moving this forward. I just wanted to pick up on Sarah's point about women leaving hospital without heparin. I guess that's why we're having discussions about standardised dosing, because one of the problems is if you've got there's issues that get created along the way with when you're altering doses on patient weight, which is not only a prescribing issue, it's a dispensing issue for pharmacies, and often women are leaving hospital, as you say, without their heparin, which shouldn't be happening. So as I say, there's not going to be one thing that we're going to do that's going to solve this, but hopefully the evidence will come through, and we just need to think about policy levers to make this more seamless for women who essentially get caught up in our structural issues that we have in the NHS.
I'm Shilpa Ratnaparki. I work in Darlington Memorial Hospital. It's just regarding the early pregnancy. Since we are saying, because one of my colleagues now just said there is a risk of ectopic pregnancy and the bleeding, maybe something we can consider if somebody is a high risk of VTE and they need a high dose of thromboprophylaxis, maybe considering an early viability scan before starting on thromboprophylaxis. That is maybe. I know I'm putting pressure on the ultrasound department too much. Second question is, it's regarding the postnatal. Somebody had the cesarean section, yeah, and the VTE score do change. We always have the dilemma. Some trainees, they put the booking weight when prescribing the VTE prophylaxis, whereas some women, we say they need to wait because there is a drastic change in the weight from booking till delivery. Sometimes they gain 10 kgs, 15 kgs, 20 kgs. So in that situation, this is always a problem. When somebody had a cesarean section, they don't get to wait because they can't stand. And then these are the women who are high risk actually needing to take the thromboprophylaxis on time, and it gets delayed because they don't get to wait. Is there any consensus that what we should be doing in that situation?
All I can say is what a mess we've got ourselves into, that we're thinking about what dose of low molecular weight heparin am I going to use, whereas there's no evidence to say, we need to alter the dose of low molecular weight heparin and they might not be better off on a standard dose. So I don't know, we've got to redesign things and make them cleaner and easier for people to deliver. But if you have somebody post-cesarean section who can't walk, they should be receiving intermittent pneumatic compression whilst they're lying in bed. Anyway, I think that we need to be thinking about using IPC more. The stockings can be thrown away. We'd save NHS England about £80 million a year. We're ordering in 250,000 anti-embolic stockings a year through an NHS procurement, and there's no evidence to say they have any benefit. There's only evidence of harm in stroke patients. So as I say, the study coming through, if that shows there's no benefit from stockings in low-risk surgical patients, we really need to say to NICE, you have got to change the guidance and stop us using stockings. So I'm back on stockings again, sorry. So yes, that poor lady needs IPC. It's a messy muddle, isn't it, about what to do with someone who's put weight on. Ideally, we might end up with just 2 doses, and so hopefully she'd be under 100 kilograms and she could just have a standard dose of low molecular weight heparin. But we don't know yet, do we? And we haven't heard what the Royal College of Obstetrician Guidance is going to say either.
Thanks. Thank you all for sharing your expertise with us. One thing we have been doing relatively recently in Leeds, which I'm not saying is perfect, but it is helping getting more high-risk women into starting low molecular weight heparin thromboprophylaxis, is we have a triage system, which is consultant-led. It's not a great job for the consultants involved, but it's good in the sense that women who, as soon as they are electronically registered with the midwife, which is usually at around 6 to 7 weeks of pregnancy, if they are high risk, i.e. previous VTE, rarer thrombophilias, like Bev said, as antithrombins, and APLS, etc., they are we get informed straight away, and they are booked to the next OBS heme clinic, which happens every Friday. So they start low molecular weight heparin quite quickly, which is great. But obviously, we're missing all the other women who require VTE thromboprophylaxis for softer reasons, as per the current guideline.
So I think there's obviously examples of really good practice going on, but it's not consistent, and that's the biggest problem we have across the system. So quite rightly, there needs to be rapid access pathways, because we are not going to be able to ask all GPs to prescribe thromboprophylaxis for all women who need it. Some might, and we'll hope to break down some of those barriers, but like I said, there's not a one size is going to fit every system approach. So I think those examples of good practice are something that we need to share the learning from, and try to embed in the system. But as Beverley said, we also are working under financial constraints, so we just need to think about the ask. I just wanted to come back on the issue about having a scan. I think there have been maternal death reports, I'm aware of some, where women have been denied thromboprophylaxis because they haven't had a scan confirming an intrauterine pregnancy, where an ectopic has not been suspected just because this woman hasn't had a scan. That's a real barrier, and I guess my anxiety is creating more barriers for women to access the heparin as and when they need it. So I don't disagree if you have a woman that you're thinking about putting on treatment dose, like quote heparin, or perhaps she's in with a suspected ectopic in hospital, that's different, but I would be very anxious about introducing additional steps and barriers with potential cost that would slow down access.
And I was going to come in and say something similar, because we have to recognise, and presumably Beverley, you showed this, that there is a perception that women's risk increases throughout pregnancy, but no, the risk is there from very early in pregnancy. So actually anything that delays their access, I would entirely agree with Kate, is something that we need to be guarding against, really.
We are in a time as well where we are moving to electronic records and women self-refer using electronic forms online. We need to have the right questions in there, but it needs to be standardised nationally so that all units are asking those questions, which will help us to identify those women who are high risk for various reasons, not just VTE. So there's something there around how women actually get into maternity services in the first place, and how do they help us to identify that they are high risk and need a little bit more.
And I think we also have to recognise the place of pre-pregnancy advice. And it was interesting, whoever it was that was talking about soft risk factors. You know, obviously, I am a public health physician. We do need to recognise what we could and should be doing from a public health point of view to address some of those softer risk factors before women get to pregnancy services. Maybe not within the remit of all of you, but maybe Kate within your remit.
There's a couple of questions on the app, but I think while we've reached here and sort of wrapping up the session, I just do wonder what I suppose the question to Kate, particularly Kate and Marian. It is a national health system. This is a national problem. Why are we not focusing our efforts on a simpler score, obviously important, but actually getting these prescriptions back out to primary care? Because it's part of educating the GPs that this is important. It's part of educating all our healthcare workforce. And equally, a lot of these women might be seen in the obstetric unit every 4 weeks to be given the metformin, the tinzaparin, and all the rest of it. But I think everyone here who works in maternal medicine knows that the challenge is every 4 weeks you have to re-prescribe. It's the same pathology for the same duration of the pregnancy that is never addressed in primary care as an ongoing prescription. And we sit here and hear the evidence of lifelong risk, cardiovascular risk. Is that such a difficult thing to address?
I think we potentially are our own worst enemies, though, because we've the structure of the way that we provide maternity care has excluded GPs in a lot of ways. So they don't provide any routine antenatal care comprehensively. So I think if you speak to GPs, which I've done a lot, and I work with the GP lead for women, the National GP lead for Women's Health on this issue, GPs feel really underconfident prescribing. So I don't think it's as much as they won't. I think we need to think about ways to support and enable them to do so.
And at a wider level, GPs have never taken part in any form of thromboprophylaxis. You know, if you have a hip replacement, how many have they done? 150,000 a year. We have to prescribe the low molecular weight heparin or whatever in the hospital and give the patients the set amount, knee replacement, the same. So they don't want to be part of hospital care, and I mean they are a shortage speciality, so they don't want any more work.
I'm just more trying to think of the national money as opposed to the
Janice,
different budgets.
I think you'll agree, in Scotland we don't have the same issue with that, in that the GPs do prescribe thromboprophylaxis and metformin, and it does go into their repeat prescription. I'm not saying that it changes our outcomes for women, but it's definitely easier for my haematology obstetric clinic. Women who've had previous VTE can just go to their GP, they'll have it on a discharge letter that for a future pregnancy they'll know they should ask for it, and they do get prescribed it. And if they need to have change from a Pixaban to treatment dose, low molecular weight heparin, then the GP can prescribe it, phone EPAS, and they will have a scan arranged. So it does make things much easier having primary care involved, I would imagine.
And do you have internal constraints that you can only prescribe a month's low molecular weight heparin? Well, you need to tackle that, I would say, because I always do 3 months, so they're not popping back all the time. I have to talk to pharmacy.
True. A couple of questions on the app, and they are slightly less contentious. One of the issues is that if assisted conception, for example, is one of multiple risks with a score that initiates prophylaxis from 28 weeks, it defeats the purpose of acknowledging the IVF confers greatest risk in early pregnancy. I think the question is there going to be a move away from these times for starting treatment, but it goes back to...
Sorry, what was that?
So an IVF pregnancy is a risk factor to start thromboprophylaxis from 28 weeks, not to give thromboprophylaxis in early pregnancy.
The risk with IVF is only in the first trimester, so it needs to come out of the second, third trimester assessment, doesn't it? There's a level of complexity here that's going to make it a simple risk assessment or very difficult. We'll have a go.
And then another question from Nicholas Patney. Hyperemesis and VTE risk. Is there a severity of hyperemesis that starts to matter with respect to VTE risk?
So I was talking to Melanie Narnett yesterday because she's written some guidance about it. And it's really if someone is totally immobile. And she was saying, and I hadn't appreciated the depth of the difficulty, was that some women are so nauseated, they don't actually vomit, they're so nauseated they can't move. If they move, they get nausea. If their child comes near them, the smell of the child might make them feel sick. So they're just confined to their sofa or their bed for the first few months of pregnancy. Well, that's very difficult, isn't it? We need to increase awareness of the risks of doing that, because you're very immobile in that setting and probably quite dehydrated, so that's very high risk.
And it goes back to your point that you made about severely unwell and putting that in a scoring system.
So I think we'd say when you have limited mobility, then you have a severe problem.